Thank you. Thank you very much. I appreciate the opportunity to speak. Thank you, Julio, for inviting UNAIDS to be able to present on 2.0. And also thank you very much, Craig, for really evidencing the passion that I think we as public health professionals need to bring to our jobs. As a side note, I just also want to mention I'm a firm believer in treatment as prevention. I just want to say to all of those people who I've been coughing next to these last 3 days that I've been on my Zithromax and I'm confident that I've not been infectious. So I'm hoping that I do not hear differently over the next period of time. I just want to briefly cover some of the rationale for the next 3 pillars of treatment 2.0, point of care and other simplified lab tests, reducing costs and adapting service delivery, and then briefly introduce community mobilization. Certainly in terms of, actually, sorry, before talking about this slide, I guess I just also want to say there's been some tension at this meeting about whether or not we compromise our aspirational goals and targets in response to what seem like maybe the likely financial limitations that are present now, or whether or not we should not limit our horizons to what seem to be what we're being told are those financial limits. My background, as Nathan said, has been in implementation for the last 10 or 11 years. And so I just want to remind us that whatever the financial barriers are, or whatever the financial limitations, we know that we've all had challenges and obstacles regarding implementation. And so the theory and the strategy regarding treatment 2.0 is recognizing that although we've done an amazing job over the last 10 years, we haven't been able to accomplish enough if we really want to get to universal access regarding the current numbers that are quoted in terms of the numbers of people who have CD4 less than 350. And certainly if out of this meeting and other meetings like this, we change what we mean by universal access to include almost all people with HIV, we're going to have to redouble our efforts to simplify treatment. So in terms of Pillar 2, which is promoting point of care and other simplified lab technologies, these are things that have been part of the public health approach: increased use of rapid HIV diagnostics, better diagnostic algorithms, the commercialization of new CD4 and viral load point of care tests. And I want to mention that often that we sometimes get into some semantics about what point of care means. It doesn't necessarily mean at the household level by a community health worker, but it's really moving diagnostic and monitoring tests further and further to the periphery. Certainly we need simplified pediatric diagnostic testing, using dry blood spots with has been certainly an important innovation, but it's not sufficient since it still requires samples to move and results to come back, as well as making sure that there's quality assurance and quality control for new technologies as well as the current technologies. In terms of CD4 testing, we know that CD4 testing still remains limited in many settings, and it's particularly limited as we are increasing access by moving HIV care to the periphery. CD4 machinery, lab equipment tends to be at district hospital or sub-district hospital level. When we move to primary health care, we're primarily right now relying on sample transport systems, and those have many challenges, as you all know, in terms of proper specimen handling. Timely return of results is quite difficult. It's inconvenient for patients who do not get the result in the same day, and if we want to think about whether or not their treatment, whether or not they need to be initiated on treatment, or if their treatment needs to be, regimen needs to be adjusted, they're having to come back for the results. Sample transport is rarely daily, and I think that we probably have a lot more sample mishandling and some probably degradation of samples because of of how sample transport's been arranged. And so therefore, an intensive focus on point-of-care CD4 is crucial. Moving on to viral load, access to viral load testing is extraordinarily even less available. As far as I know, in terms of sub-Saharan Africa, only South Africa includes viral load as part of national guidelines. Certainly it's a question how we would approach treatment as prevention, but if it turns out that treatment as prevention, at least at initial stages, is targeted towards those who have greater likelihood of transmission, it would be difficult to do this without viral load testing, as well as, of course, there's increased interest and importance of using viral load testing as part of treatment monitoring, and so it will be difficult without treatment point-of-care diagnostic monitoring tools. And so there are a few products that are either that are quite close to commercialization. Mentioning just a few, there's the Samba. GeneXpert will be developing, using the GeneXpert platform for TB diagnostics. There should be viral load. They should be able to use that platform for viral load testing at relatively unsophisticated health centers within a couple of years. There's Roche point-of-care viral load, among others. It's important, though, to think about what are the respective roles of each of these testing platforms, and at what place in the health system these individual machines are useful. And historically, one of the criticisms of the diagnostic and monitoring tools that we've used is that they've been developed in first world markets, in richer markets, and they've been retrofitted for situations where the infrastructure is not as strong. But the innovation didn't necessarily, or the invention didn't necessarily occur with those markets as the primary goal. And it, particularly for laboratory, it's been quite difficult for new companies, new machinery. The opportunity cost for entry into that market is difficult. It's a smaller market, the machinery is more expensive. And so when people ask, well, what's different about treatment 2.0? We know these things already. I would say it's really that there's a concerted effort to work within the UN system, within the wider range of partners that Craig mentioned, as well as with innovator companies, to really move the innovation or to create a strategy for innovation that's guided by the principles of the public health approach, rather than somewhat backwardly trying to retrofit to what had been available previously. In terms of reducing costs, Craig's mentioned already, there are certainly opportunities in terms of first-line therapy as well as second-line therapy, both in terms of move towards generics within the second line and use of innovative mechanisms like the medicines patent pool. And certainly we have to keep in mind that up to 60 or 80% of costs for HIV care and treatment is not related to drug costs. And so there's a lot of important activities that we need to focus on in terms of reducing costs. I just want to mention this is this is from an article from 2009 regarding PEPFAR data from a couple of years before that, from 2006. And this is the ART cost, the average ART cost in a number of national programs. And although the data is somewhat old, I just want to point out that at that point, PEPFAR had already permitted the use of generic PEPFAR funds for generic medications as long as they had been FDA expedited approved. And even during that period, the average cost of ART was enormously higher than what in fact were the lowest available prices through FDA expedited approved ART producers. And so there's a lot of room to move even within our current system for looking for to understand what is the reason that we're not providing care as efficiently as could be. In terms of Pillar 4, adapting service delivery, fundamental concept or is moving all components of care closer to the person, and with some of the intentions having to do with reducing loss to follow-up, but also I think has been mentioned in this meeting that when we talk about patient convenience and feasibility of patients to make their way to health care, it's important that these service delivery are at places where they can get to. So in terms of expanding counseling and testing, it's an increasing focus on community-based counseling and testing, decentralizing treatment, initiation to primary health care, decentralizing maintenance ART as well as non-ART to PHCs. And there have been a number of innovative examples MSF has described about moving some of the aspects of both ART and non-ART care to community systems. A shift certainly away from standalone ART services to integrate with a wide range of other services. And again, decentralization will ideally reduce loss to follow-up as well as costs. And certainly in generalized epidemics, we know that ART should not be managed only by specialists. And until recently, ART has remained primarily medical doctor-driven, physician-driven for initiation, but often for maintenance as well. And I think that's both from national policy as well as at certain times, nurse practice acts have made it difficult for nurses to initiate or maintain therapy. And so I think the service delivery barriers to the WHO public health approach are important to examine and try to unpack and solve. This is also some PEPFAR data, and it was a study by Scott Filler from 2011. Most of the information was from 2007. It's a relatively small number of small sample size, but at 43 sites, physicians, this was from 2007, physicians were required for ART initiation. Only 1 out of 43 were nurses able to start. In terms of follow-up care and treatment, again, it was enormously physician-dominated. I think the information, if it was collected right now, would be different, but I don't think, it might not be quite as different as we think. And then just to remind us in terms of the blue areas of the bars is that if we think about a comprehensive response to HIV, support, care, and treatment doesn't necessarily represent even the majority of costs associated with what we should consider to be this comprehensive support for people with HIV. And so there are really opportunities to take the lens of Treatment 2.0, which is radical simplification. We can take that lens to the other domains of HIV services. And then lastly, in terms of the community mobilization arm, there are 2 components of that. And Paul will speak in general about that, but the 2 arms have to do with advocacy and mobilizing communities, and to think about what are the ways that community service providers can provide increasing parts of HIV care and treatment, and or are there ways to use the networks that have been established of advocates within the PWA community to take on additional roles. And certainly the 4 pillars of Treatment 2.0 will not succeed without community mobilization. So I'll turn to Paul to complete this discussion. Thank you.